Welcome to RP Presents Representation in Radiology, Our Diverse Future. Our program will begin shortly. All attendees are entering the webinar in a muted status, and you will remain on mute throughout the duration of the webinar. Thank you for being present for this important conversation. Welcome to RP Presents Representation in Radiology, Our Diverse Future. Our program will begin shortly. All attendees are entering the webinar in a muted status, and you will remain on mute throughout the duration of the webinar. Thank you for being present for this important conversation. Welcome to RP Presents Representation in Radiology, Our Diverse Future. Our program will begin shortly. All attendees are entering the webinar in a muted status, and you will remain on mute throughout the duration of the webinar. Thank you for being present for this important conversation. Our webinar will now begin, and I'll hand it over to Dr. Andrea Birch.
Hi, everybody. My name is Andrea Birch, and I'm a professor of clinical radiology at Vanderbilt University Medical Center. It is indeed my pleasure to welcome you to our webinar. We have a diverse group of panelists, including Tina Chatterjee, a third-year medical student at Meharry Medical College with a strong interest in radiology. She currently serves as president of the Radiology Interest Group at her institution. She co-leads the annual American College of Radiology Medical Students Symposium. And on top of all that, she's a peer scholar ambassador. Dr. Nicole Cole is a breast imaging radiologist and serves as practice president for Radiology Partners Georgia, medical director of the Piedmont Columbus Regional Breast Care Center, and chair of diagnostic radiology at Piedmont Columbus Regional. She earned her medical degree from Meharry Medical College, completed a radiology residency at Tufts University, and breast imaging fellowship at Cambridge Hospital, a Harvard University affiliate. Next, we have Dr. Anthony Disher. He's a breast imager with Radiology Alliance in Nashville and the past chair of the Department of Radiology at Meharry Medical College. Dr. Disher completed his degree at Meharry Medical College, followed by an internship in internal medicine and a residency in diagnostic radiology at King Drew. Last but not least, we have Dr. Marta Schulman. She's a pediatric radiologist and serves as professor of radiology at Vanderbilt University Medical Center and medical director of diagnostic radiology and chief of pediatric radiology at Monroe Carroll Children's Hospital at Vanderbilt. She completed her residency in both pediatrics and radiology and a fellowship in pediatric radiology at Boston Children's Hospital. She is a past president of the Society for Pediatric Radiology and former vice president of the ACR Board of Chancellors. Dr. Schulman was born in Cuba and came to the US as a 10-year-old child. The next slide brings context to why we're here. Christina Chapman et al. Used data from 2010 and found that underrepresented minority representation for practicing radiologists in the US was less than 7%, despite the fact that the distribution of URM population in the US was 30%. We know it's been predicted that a majority-minority flip will occur in the next couple of decades, And as a radiology workforce, we need to be prepared to take care of this increasingly diverse group of people. So consider this a call to action. We need you. So raise your virtual hand if you've been in our house. If you've seen a CT scanner or a 3D printer in our department, for instance, held an ultrasound probe, sat in a radiology reading room, held the mouse and scrolled through some images. Did you observe a biopsy? Maybe you had a conversation with a radiologist. What did you think? Let us hear about your experience. What do we do in our house? Well, with the next slide, I'd like to present an actual patient's case to illustrate what we do in our house. Who lives in our house? What rooms are available? How are cases generated? How are recommendations established? And how do we impact our patients' care and outcomes? This patient presented to the ED with rectal bleeding. The next slide shows select images from her CT scan. We have transverse images and coronal images from her CT scan of the abdomen and pelvis. Does anyone see any of the findings? Well, the patient does have some colonic diverticulae, which may actually explain why she's having rectal bleeding, but she has a few other findings. Does anyone see the large cystic pelvic mass? An incidental finding that requires workup with ultrasound. And if you look a little more closely outside of the abdomen, does everybody see that mass in the right breast? It's also an incidental finding that requires further assessment. Now, the diverticular disease, that's not going to kill this patient. The possible ovarian cyst arising from the pelvis, that's not likely going to kill the patient either. But the breast mass left undetected may have certainly killed this patient. You know, the natural instinct is for us to stop looking once you identify a finding. But as radiologists, we're challenged to keep going, to keep looking. So with the next slide, we have what's called an impression or an opinion, which tells the clinicians what we saw and is always or usually followed with additional recommendations, utilizing evidence-based guidelines to direct next steps to achieve the best health outcome for the patient. So the recommendations were followed, and on the next slide, we see that this patient got a diagnostic mammogram. These are routine images which demonstrate an irregular, spiculated, hyperdense mass in the central breast with skin thickening and nipple retraction. These findings are worrisome for malignancy. The next slide illustrates images from this patient's ultrasound. The ultrasound confirms that there indeed is a mass. It's irregular, it's hypoechoic, it's got distal shadowing, microlobulation, marginal angularity, and it's too worrisome for malignancy. So what's the next step? Well, as a teaser with the next slide, we'll show that the next step is indeed, if you said biopsy, that's exactly right. This patient requires a biopsy. And we can see both the mass that's highlighted with the red arrow and the white echogenic line, which is the needle inside of the mass. So what have we learned from this case? Well, a couple points. One is that it takes a cadre of radiologists to evaluate one particular patient. So this patient got seen by the ED radiologist, a breast imaging radiologist, an ultrasound radiologist. She got seen by potentially a radiation oncologist, an interventional radiologist who may have put in a port. All of these radiologists took care of this patient. And in addition to that, when you bring in a breast surgeon, a medical oncologist, a gynecologist, you have even more people all communicating and collaborating to take care of this patient. It tells us that we look for additional findings. We understand that our job isn't done when we find just one thing. We keep looking. And now I'd like to turn our attention to our panelists who have experiences of their own, who have thoughts about ways that we can perhaps increase our diversity in our profession, in ways that we can better align with our patients and show medical students a pathway to do the same thing, to become engaged. I'd like to first start with Tina Chatterjee. Tina, you're a peer scholar. What exactly is that? And how are you selected?
First of all, thank you so much, Dr. Birch. That was a great introduction. So the peer scholarship was a research program that I did in the summer of 2020. It's organized by the American College of Radiology. And I believe it stands for the Pipeline Initiative for the Enrichment of Radiology, and it recruits first and second year medical students that have an interest in radiology or want to learn more about the field. And I definitely applied to that. And I was matched with Dr. Birch. So students that are accepted into the program, they're matched with sort of a radiologist, and they get to focus on a specific case that or a specific field that they're interested in. And then based on that, we focused on like a specific case and then wrote it up, and then it was published on the ACR Case in Point. And I have to say that experience was amazing, because not just because of the case, I got to learn so much about breast imaging, and I made two amazing mentors, one of whom is Dr. Birch, and still keep in touch very frequently. I definitely learned a lot. And originally, I believe the program was in person, but when I applied, I'm thankful that the ACR didn't cancel it, because at Meharry, we do have a requirement after first year to do a summer research program. And that's why I applied to the peer program. And I'm very thankful that it became virtual, because that not only allowed me to continue the research program, but I met so many different people with similar interests as myself, other medical students across the country, radiologists, residents, and so many more people. It was a great experience overall.
Thank you, Tina. I'd like to ask the other panelists the same question. And the question is, what piqued your interest in radiology? Looking back, what was it that made you sign up to become a radiologist? And I'll ask that question first to Dr. Disher, then to Dr. Cole, and then to Dr. Schulman.
So I became initially interested in radiology when I was in college. My grandmother was diagnosed with breast cancer. And so after that diagnosis, I was the designated driver to take her for radiation therapy treatments. So upon driving my grandma to the hospital to get these treatments, well, I'm sort of a talkative guy. So I would be talking with the people, the technologists, and I got to meet the radiation oncologists. And I thought, I'm a science major here. I like equipment and machines. And I said, I think this is an area I'd like to go into. So that was my initial interest in radiology.
Thank you. Dr. Cole?
Thank you, Dr. Birch. I would say that my interest peaked after my mother was also diagnosed with breast cancer at the age of 48. My mom was diagnosed and it ended up being stage 0 as a result of early detection. She is now a 23-year survivor. On the other hand, my grandmother was also diagnosed with breast cancer, and she was 83, and she actually succumbed to breast cancer. So I've seen both sides, and I think with being able to experience both sides, I realized that access to care plays a huge part in early detection. My grandmother was very private, and she didn't have a lot of resources. And so in her case, she did not have the patient education, and she did not have the access. And I felt that if I could be a part of the process and helping patients have the education and the access, then I wanted to do something to create that change. I also have a love for photography and pictures. And so I love to do that as just my pastime. And so when I started rotating through radiology, especially with Dr. Disher as one of my mentors, I really enjoy just looking at pictures and kind of being the doctor's doctor and kind of being that jack of all trades and being able to look at various different pictures. So,
Thank you, Dr. Cole. And Dr. Schulman?
Thank you so much, and thank you, Andrea. For me, it was a little bit different. I actually had thought about going into pediatrics, but then as I continued on in medical school, and I did do a full pediatric residency, as you said earlier, I just wanted more of a challenge and more of a participation in different areas. So in pediatrics, I felt that I was going to be dedicated to one single area, whereas in radiology, I get to meet so many colleagues in so many areas. So my day is made up of meeting with the surgeons, meeting with the gastroenterologists, the cardiologists, and all of the different entities that all of this that they deal with in their own patient population. So I'm part of every part of pediatrics as a pediatric radiologist. And in addition, the patients that I see, there are every day you meet so many patients. Like Andrea was talking about, that one patient that was picked up on the CT scan. That wasn't the only patient that radiologist saw that day. I mean, that radiologist, in addition to saving this woman's life by finding the breast cancer, she or he also continued on and read many other scans and saved a lot of other people and met a lot of other conditions. And then for me, in addition, pediatric radiology is even more special because children get better. So, you have the ability in adults to make them better many times, but children, it's in their nature to get better. So a lot of what you do and a lot of that you input, you get a lot back in your patients getting better. So it's just a wonderful, wonderful professional life and professional activity with tremendous colleagues and a lot of patient interaction in a radiologist's day.
Thank you, Dr. Schulman. I'll ask the next question to Dr. Disher. It was recently reported in the New England Journal that the number of Black male medical students nationally has decreased even further, representing 2.9% of matriculants nationally in 2019, despite a growth in the Black population. As we try to diversify our profession, what do you see your role as a Black male radiologist to help correct this inequity?
Well, Dr. Birch, that's a terrible statistic. We have failed as academicians in academic centers across the country to not address this issue with in terms of the Black male medical student. It's our responsibility to be involved and get aggressive with some type of approach to this. It seems like there's no apparent strategic intent from some of these medical schools to rectify this situation. So I say get involved. So how are we going to get involved? There's the saying that it takes a village to raise a child. We have to start early. So as physicians, we need to get involved at the middle and high school level with the education of the students and start mentoring. Perhaps we could participate as volunteers in some of the high school science fairs, become involved with some of the programs at some of these magnet high schools. There are also pipeline programs that we can become involved with. Meharry has something called Meharry Now Day, where the faculty and students participate in a day of science with 2 sponsored middle schools in the Nashville area. I believe the Student National Medical Association has youth science outreach programs or enrichment programs. So that's an opportunity for students and radiologists to get involved. But another major area, I think, is to be involved if we are academic radiologists or even in the communities of some of these academic centers, to be on the medical school admissions committees. Those committees review the candidates that are coming to medical school. So we can have our input in the selection of these medical students, which I think should be a little bit more holistic than it is. There's a lot of emphasis on just the MCAT score, but we need to look at the candidates' life experiences and what they would bring to the medical profession as an individual. Also, a lot of the medical students now have offices of diversity and inclusion. When we're mentoring young people, we can encourage them to network and contact some of these offices to find out about what some of their requirements are for selection into their particular programs. And finally, perhaps some financial incentives. We could talk with foundations that are out there and come up with some scholarships to help sponsor some of these Black male applicants. So that's just a few of my thoughts.
Thank you, Dr. Disher. I'd like to ask the next question to Dr. Schulman. I'd like to know how many of the attending radiologists and trainees in your residency were Latinx?
Very few, if any. I mean, I never had a mentor that was Latin, and I was actually very happy when they were women. I mean, I'm old enough that there weren't that many women around when I was in training, and I had some great mentors who were men, and one, but there was one woman specifically, and the fact that she was a woman really meant a lot to me as an example of what could be accomplished. And that woman is Rita Thiel, who is she's actually the first described the person who wrote the New England Journal paper on ultrasound for pyloric stenosis. So I followed in her footsteps. I went to the same residency program that she did, and she was my teacher. She taught me ultrasound. So that was very special because she was a woman. And but as far as Latins people, even as colleagues, there are just very, very few people who are of Latin background in radiology. And everything that Dr. Disher said about Black men, I think that applies to many of us, and particularly Latin females.
Did you feel isolated during your residency or early on in your career? Was it difficult to try to get into or seek leadership positions early on? You said you had a mentor and you followed in your mentor's footsteps. Did you meet a lot of challenges on the way doing that?
I think one of the challenges that women have in some ways is being taken seriously. I mean, when you have an idea, you have something, or you have the classic problem with, are you being aggressive or versus not? It really is it's a special type of balance that a woman has to walk in during a career and leadership, and having mentors that can help you do that is very helpful. But many of us have had to create our own path.
I'd like to ask the next question to Dr. Cole. You are active in breast care screening outreach, bringing screening programs into the community. Tell us why this is so meaningful for you.
The reason community outreach and bringing screenings to the community is so important is one, because my foundation, which is at an HBCU, Meharry Medical College, our mission is to serve the underserved. And so in order to do so, we spend a lot of time in the community. And a lot of times that we had volunteerism and community outreach in areas that did not have access to care. We focused a lot on Healthy People 2010, and then it progressed from there. And so this was always our focus. Also, I feel that patient education influences patient behavior and changes their knowledge and their attitude towards their health. And so there are a lot of patients who just don't come and get a mammogram because they feel that the radiation is too high. But if you educate them about it's equivalent to the same radiation, the radon that you get just from the Earth's core or from taking transatlantic flights, or living in Colorado, for example, if you explain this to them, then they have a better understanding of the things that are limiting them from doing the best thing for their health. A lot of patients think that if I don't have a family history, that I don't have a risk of getting breast cancer, so therefore they don't come for their mammograms. And so when we educate them that only 15% of those diagnosed with breast cancer truly have a family history, it makes a huge difference in their perspective in whether or not they choose to come for a mammogram. My motto is to meet the patient where they are, wherever they are. So I'll go into the community, I'll go to churches, I've gone to balls, community organizations to speak, tennis matches, TV and radio, as well as other media outlets to talk to the community about the things that I actually talk to the patient's bedside when they're here for their screenings and diagnostics. If I'm able to bring the education to the patient, I feel like it's more successful to capture the patient. One of the largest events we do is the annual breast cancer luncheon, and it's usually attended by about 1,500 people. And we do a theme each year. And we've done Top Gun, Maverick, we've done Star Wars, we've done pirate theme, Treasure Your Chest. So we do these different themes to attract the patient to the actual event. And while they're there, we normally have a humorist, because a lot of times laughter is the best medicine. So we have someone actually lighten the mood with, a few jokes, and then we educate them. We educate the community during that event. And so that's pretty much why I'm so passionate about bringing screenings to the community, because it started with my foundation at Meharry Medical College and our mission.
Thank you, Dr. Cole. Tina, this next question is for you. Radiology is more than just new technology in imaging. Are you excited about radiology's role in mitigating healthcare disparities, finding climate change solutions, and incorporating artificial intelligence algorithms to optimize practices? Does that excite you?
Yeah, thank you so much for that question, Dr. Birch. I just want to say thank you to Dr. Cole for her previous answer, and I definitely stand by our school's motto is to serve the underserved. And I think Meharry does a great job of going into the community and actually reaching the people where they are, because there are so many people out in the community that just don't have access to transportation, and that's maybe their biggest limitation. I think that Dr. Cole and others like her do an amazing job of just going to the people where they are. And that's where it begins. That's where you can start to mitigate these healthcare disparities that, if they're not solved, eventually lead to unfixable outcomes. And so these screening programs specifically, or for example, for breast imaging, are so necessary for these women that can't or don't have access to healthcare, don't have access to transportation, and they don't know it now, but in the future, if they're ever diagnosed with breast cancer, they can't do anything about that, or that they won't be able to do anything about that. So I definitely think going to the people is where it begins in terms of mitigating healthcare disparities. The question about climate change, that's an interesting one. I definitely think radiology does have a big role in or can have a big role in helping mitigate climate change issues, specifically because it's centered so much around using machines all the time. So practices like putting machines possibly on standby mode, or like so much data is stored on PACS systems. If those are not turned off, you can use maybe like some kind of intelligent, like introduce some kind of artificial intelligence software that automatically puts it into standby mode or turns it off or something like that. I'm not entirely sure if those systems exist already, but something like that can be a start to mitigate climate change issues from radiology's perspective.
Thank you, Tina. I'd like to direct the next question to Dr. Disher. I want to know, how did you inspire medical students to go into a field as chair of a historically Black School of Medicine that doesn't have a radiology residency? How were you able to champion radiology in that setting and advocate and show students its value? Were you able to create allies that could help?
So what I tried to do is, first of all, get the student excited about what it is that we do. A lot of them have these misconceptions that we just sit in some dark rooms and talk to ourselves. So I have to get rid of that and let them know we are actively involved in the healthcare of patients. So we have the opportunity to start at the very first course. When the students come in the summer, there's something called MAPS. And in that program, it's an assessment of the students as they adjust to the academic life of a medical student. So I have the pleasure of giving this introductory lecture. So I use that as an opportunity to just brag about what we do and emphasize that we are a service specialty, not just a technical specialty. And we need all hands on deck. We need folks of color in what we do, just like any other subspecialty. And what we do is exciting. We are solving on the front line of solving the medical problems of these patients. So if you want to be involved with something such as breast health care, like a lot of us are, you're dealing with patients and advising them every day. You're performing procedures on those patients. So you're not just sitting in the reading room reading mammograms. Or if you're an emergency physician, you're doing procedures on those patients and involved with the ED docs with those particular patients. So, and we can go on with that. The other thing is I tried to keep radiology in the student's mind throughout the 4-year educational experience. So in some form or fashion, I would either have some type of lecture throughout the 4-year experience, and we end with a 4-year required clerkship. It's only a 1-month required clerkship in the 4th year of the medical student experience, but we have opportunities to lecture throughout the entire year. So I had to collaborate with a lot of the course directors so I could get some time. And we only had 3. Let me tell you now. At a HBCU, we only had 3 to 4 faculty. So we're humping. So we got to take care of clinical responsibility, but we also got to talk to these students. So we go in and we give these lectures to the students embedded in, say, general surgery or the GI module in some other course. So you got to collaborate with the course directors. And the clerkship coordinators. Then I have the opportunity to work with people like Dr. Birch. Although I've been knowing Dr. Birch for a long time, we have the Meharry Vanderbilt Alliance. So that's another organization where I can work with both organizations and we can set up another type of educational opportunity or experience for the students that I don't have. We don't have a lot of resources at Meharry for research in radiology. So they could go and work with someone like Dr. Birch over at Vanderbilt and have some type of research exposure, which is very important for the student. So get in, dig in early, excite the students about what it is by showing what we do, and collaborate is what I say.
Thank you so much, Dr. Disher. The next question is for Dr. Schulman. I'm wondering, do you have a large fraction of Latinx patients in your practice?
So we have more than there used to be. There's more where I grew up in New York, and before coming to Vanderbilt, I worked at Bellevue for 3 years, and there were a lot of Latin people there, a lot of Latin co-workers, very many. When I came to Vanderbilt back in 1988, there were very few. I mean, there really were not very many Latinos around, but the Latino population has really increased quite a bit in the years since. So we certainly see a lot more people that are Latin, and I've been so impressed by what Dr. Cole and Dr. Disher and everyone here has been saying about bringing in all of these students from the very beginning, so that we can have a doctor population that reflects our patient population. I think that's just very important. And another point that's been said that I think is really critical is how we need to bring the care to the patients, because a lot of the patients may not even understand where to go. They often will use the ED as their entry point into the care system. And they may not know how to navigate the system. So I think that there are so many ways that we need to more than just one person, but just organize so that we can take the whole population and do a little bit, improve the way that we deliver care as a whole. We have to start with a few people at a time, but I think there is a lot of work that yet needs to be done.
Thank you. And one last question along that same line. Do you sense that your background is meaningful for some of the families of the patients that you serve?
I think when people hear their language, I think their eyes brighten. So the fact that I can speak the language, I think that really makes a big difference. So that little bit of understanding does open a door. And it's beyond the language, it's also the culture. I mean, when a patient tells you that they have pain or something is wrong, I mean, from the culture that they come, it may have a very different meaning. So we may not even understand what they're telling us, even if we understand their words, unless we understand the cultural background that they're coming from. So there's so much more in addition to language that we need to learn. And the only way to really learn it is by having people of varying backgrounds in the population. And I think we're taking baby steps, but we're taking very good steps in the right direction to do this. And I love what Dr. Disher is doing and Mahari. I think it's just terrific.
Thank you, Dr. Schulman. The next question is for Dr. Cole. Have you been able to increase breast health awareness in communities, Black and Brown communities? And I'm sure the answer is yes, but I'm also interested in knowing, how are you doing that? How could you tell a radiologist in another city what you're doing, that they perhaps could use some of those same things to increase awareness in their own communities?
We are definitely increasing Black and Brown patients. I would probably say approximately 50% of our patients are of color. I think that if we have a healthcare system that is inclusive and diverse, that gives the patients the best care, because they feel that they're included, or they have a physician that actually looks like them and understands them. A lot of times we don't understand the culture. So a lot of times healthcare systems don't have culture sensitivity training. And so it's difficult to relate to other cultures. And I think if I make the effort to go into the community and talk to the patients, they see someone who looks like them and they see someone who can relate, that they're able to ask questions and not. We used to have this sign in medical school that said, the only dumb question is the question that was never asked. And so the fact that I can go into the community and the patients feel comfortable asking me questions. I've had patients ask me, so many different questions that they wouldn't be comfortable asking. Do men get breast cancer? People ask me that all the time. And so these are the things that I feel like I can answer. And again, a lot of the things that I say to the community is what a typical doctor would bill as an encounter for counseling. But I'm giving that information to the community at no charge, because if I can get them in the door and save a life, it makes a huge difference. So when I do that, these patients are coming in for their first screening mammogram. I'm able to capture them. And a lot of times, what we find on mammogram is 2 years before it's ever palpable on an actual screen, on an actual physical examination. So what we're seeing are cancers that are the size of a pencil tip eraser. And that's usually 2 years before that patient would have ever felt it. So it definitely makes a huge difference. I would also say that I've partnered with, there's an organization called the West Georgia Cancer Coalition, and that's more so for our patients who are either in between jobs, in between insurance, don't have insurance. I partner with them, and it allows me to focus on the patient and not worry about if they're going to be able to pay or not. So if we do run into a situation where a patient is not able to pay, we partner with the West Georgia Cancer Coalition, and they will give the patient a coupon that actually follows them from the screening to the diagnostic to the biopsy and to treatment all the way through. And so a lot of outreach, they do the screening, but if something's found, then the patient is just left to fend for themselves. And so I try to make sure that there are programs available that will follow the patient, not just from the point of the free screenings in October, but also from the screening all the way through the diagnosis and treatment. And so continuing to partner with these organizations is key. And it's up to us as people of color in this field to find those organizations who are willing to support the community that don't have insurance, the indigent care, those who are just, I've had patients where their husband passed away and their husband's insurance was the main insurance. And so now they no longer have insurance and they've had a lapse in their mammogram. So there are, people fall on hard times and they do lack access to care. So I try to go in the community and educate them and let them know that there are resources.
Thank you, Dr. Cole. I think that one last question that I'd like for our panelists to answer is, you've all, with the exception of Tina, who it's coming, you've all had such a huge impact on patient care, on making sure that you're visible for your patients and the journeys that they have to get them back to restored health. And I guess the question is, if you're talking to a person that's at an intersection of deciding what specialty to go into, what is it about radiology for you that gives you that privilege, that extra bit of knowledge, caring, empathy, compassion that allows you to meet the patient's needs, to make sure that at the end of the day, when they come back to the breast center, Dr. Cole, or when they come back to Children's Hospital, Dr. Schulman, they're seeking you out. They're trying to find you because your care resonated with them. So what would you tell a medical student?
I typically, we say this a lot in medicine, and especially in our training at Meharry, but I typically treat every patient like they're a family member. Truth be told, my mom was in this position. And so when I see a lady over 60, I think of my mom. And when I see, a girl in her 30s and 40s. I think of some of my girlfriends. So I treat the patient as if they are a family member. And so if there's a patient over in the emergency room who needs an abscess drained and I know it's after hours, do I make the decision to put it off and say that, oh, it's after hours, it can't be done? Or do I, get a sitter and order some Chick-fil-A for the kids and make my way over to the emergency room and drain that patient, especially knowing that if they're discharged from the emergency room and they are told to come to the breast care center and they're indigent care, they probably would be turned away if they can't afford to get the abscess drained. So I try to treat the patient as if they are a family member. So keep that first and foremost. And also, radiology is changing. One of the missions of Radiology Partners is to transform radiology. And so we don't, as Dr. Disher mentioned, people think we sit in these dark caves and drink coffee all day and kind of keep to ourselves and that we're introverted. But in reality, we are an integral part of the healthcare system. And we are trying to transform how that's done because we want to be memorable. We want to show our faces to the patients. We want them to see our name on their reports now that patients are getting their reports through the patient portal. We want them to see our name and say, I know that doctor, I've met her. And so I do think that we transform radiology by being visible to the physician and the patient, who then is able to say, I know that with this particular radiologist, I'm going to get quality care. I know that they're not just going to tell me that this was found on this particular scan, but they're going to say, not only was found, but you need a follow-up in this amount of time, and you need this study over this amount of time. So we as radiologists have to be in partnership with the ordering clinicians and as well be an advocate for the patient. So we have a responsibility to two different parties. And so I think it's very rewarding at the end of the day to have that place in healthcare where you can be of value to both the ordering clinician and the patient.
Thank you, Dr. Cole. Dr. Schulman?
I love everything that Dr. Cole said. I always say, there but for the grace of God go I, and there but for the grace of God, every one of us will eventually go, because every one of us will eventually be a patient. And we as radiologists, some people don't think of radiology as a patient-facing part of medicine, and therefore they feel like, like Dr. Disher said, you sit in a reading room and talk to yourself. But that is not the way it is, and certainly it's not the way it should be, or the way we would make it as we look to the future of radiology 10 years from now. We are an integral part of the care system, and many of the patients should know us, and certainly the clinicians who take care of these patients also know us. We meet the patients on a regular basis when we do fluoroscopy. We often meet them when we do ultrasound. And we meet them on CT when we do procedures on them. So there's a lot of patient-facing in radiology. So I would say to any medical student that is looking to really impact many patients across a very wide spectrum of medicine, that radiology is a wonderful field in which you can do that.
Thank you, Dr. Schulman. Dr. Disher?
So over the course of time, I've become, I think, a better listener. I agree with my colleagues with what they said before. So I've improved on my communication with referring doctors and with the patients. I think by doing that, I understand better what their respective needs are. Therefore, I can communicate to them better what I think the solution is to their particular issue. And the other thing is, this is a great opportunity also to address healthcare disparities too. So we're in a position, for instance, with screening mammograms for women of color, to advocate that they get into a screening program earlier. And there are other areas in which we can be involved as well, like low dose lung cancer screening, and I can go on with other things. So it's just a great opportunity to interact with patients, and I also like treat the patients like a family member. What would I do if this was my mom or my brother or sister or cousin or whatever? And I actually tell them that I'm suggesting this to you because I think of you as a family member. This is what I would tell my mom. So, and that's gratifying.
Thank you, Dr. Disher. We have certainly within this hour learned a lot, had everyone just give just wonderful examples and share experiences that I'm sure resonate with a lot of medical students. And I'd like to show a slide that shows who we're looking for as we have or host this type of session, this type of webinar for medical students. I want you to see yourself. We want you to see yourselves in this picture. There's room for you. There's a need for you. So with that, the next slide gives just some resources. 3 main resources. Tina Chatterjee talked about the Peer Scholar Program. The application process for first-year medical students is currently going on and will end December 31st. If you're a first-year medical student, consider it. Go to the ACR's website, go to RSNA's website. Our big scientific meeting for RSNA is coming up. Get involved, learn some more. We need you. Thank you so much for your participation.